Hey, what is up, everybody? What is up? I apologize for the late start, but welcome to another episode of the Insomniacs Livestream on my YouTube channel. I am the host, Dr. Andrew Kim, MD. I am a board certified psychiatrist. Uh, Thank you for joining. For you regular listeners, I appreciate your support. Thanks for hanging in there. Sorry for the late start. I realized I was having some technical difficulties messing with the soundboard camera. I had to restart the computer. It happens. That's what happens. Life happens and we adapt. So, for those of you who are here, I thank you for hanging in there. I didn't even realize, that I hadn't even clicked the go live button. So, I was talking to myself for a little bit. But for those of you who are brand new, thank you for joining my channel. We do this live stream component of my YouTube channel on Tuesday nights and Saturday nights, 10:30 Central, 11:30 Eastern. So please, follow my channel, subscribe, and join us twice a week for these live streams late at night. So my channel contains evergreen videos that go in depth on specific psychiatric topics. And then the live streams are a little bit looser format. We do kind of pop culture psychology. We just do some banter and go back and forth. We do a lot of Q&A. We do go in depth into some niche topics that we can just kind of get into some nitty gritty and theoreticals. So join us. And for those of you who have stuck around even with the late start, I appreciate you. And today we are covering two different topics. Topic number one, this was at the request of several regular listeners from our Tuesday episode. Topic number one, we are talking about pharmacological interventions as strategies that you can leverage to augment therapy, counseling, other strategies you're doing to help one stay sober longer, or at the very least be used for harm reduction for alcohol use. Okay, so we're going to talk about some medication options that could be leveraged on an outpatient basis to help you in the recovery process from alcohol use. So, meds that can be leveraged, again, keywords, tools to help you on that journey, because you know me, for those of you who are regular listeners here, you understand my philosophy, right? I don't view medications as a silver bullet. I do think medications are overprescribed in America. I do think we're over pathologizing people in America. Meds are not perfect, but there are some meds that could be leveraged when appropriate to be a useful tool, not an end all be all solution, right? So we'll talk about that in depth. And second topic's a very interesting one. Second topic we're going to talk about is about a concept called protracted withdrawal syndrome. Protracted withdrawal syndrome from benzodiazepines specifically. And for those of you who are not familiar with that term, benzodiazepines are what lay people call tranquilizers or sedatives. So things like Xanax, Valium, clonazepam, lorazepam, Ativan, Klonopin, right? They go by different names. So now when I say that, that probably rings a bell. So those are what we call benzodiazepines. And unfortunately, just like with alcohol, benzodiazepines, one can grow tolerant to them. One can unfortunately develop a physical dependence on them. They are abusable. And sadly, one can also be at risk of withdrawal from benzodiazepines. When mild, with careful planning, one can maybe taper off these, on an outpatient basis. But if you've developed a moderate or significant dependence, you typically need to go into a medically supervised setting like a detox facility, an inpatient medical or psych unit, to then carefully come off these, because it can be quite dangerous. It's not just about discomfort and shakes and sweats and vital sign changes. You can have delirium, which is confusion, and you can have withdrawal seizures, very dangerous. So, but there's this other concept of once one gets past the kind of acute withdrawal phase, that there may be patients who go through what is called protracted or very prolonged withdrawal syndrome, or PWS. And, some folks feel that there is a protracted withdrawal syndrome that can last for months, maybe even a year. And some indicate that there may be some growing evidence that there may be a smaller cohort of patients where there may be some irreversible damage that is done moving forward. So the best I can kind of equate it to is an episode we did several episodes ago. It's almost akin to that concept of SSRIs and PSSD, or post SSRI sexual dysfunction, right? There are folks who, I would say most folks, recover from sexual side effects from their SSRIs within days or weeks. That's just a fact. People will disagree with me, and I know some folks from the PSSD network have reached out to me. I'm just going to say it, statistically speaking, most people recover from sexual side effects, because if everyone or the vast majority had PSSD, there would be rioting in the streets if we made the bulk of Americans who took SSRIs impotent. So I'm just stating facts, okay? But just like there is growing concern about PSSD, meaning some folks who have very prolonged recovery, months at a time, maybe a year, and some folks indicating a cohort of people who may have irreversible recovery from or irreversible damage done by SSRIs. There's a similar concept with benzodiazepines. That's kind of the closest analog that I can kind of draw for you. So this concept of, even though most people do go through acute or intermediate withdrawal and then recover, there is growing concern about folks who say that maybe even a year out that they're still having pretty significant withdrawal. And then there's some folks who are saying a cohort of people may have irreversible damage from benzodiazepines. And that's what we're going to be talking about, just to give you context, what I mean by protracted withdrawal symptoms. And I see a lot of regular listeners here. Dennis is here. What's up, Dennis? D77. Lisa from the Northwest. Thank you for joining again. So let's dive into it to be efficient here, because both topics could be just long topics on their own. So let's talk about strategies that could be leveraged for helping folks with alcohol use disorder, trying to be leveraged for harm reduction, trying to help maintain sobriety. And we're going to go through a few, okay? But number one, before I do that, again, please understand that my primary recommendation, well, let's first start with this. I'm not your personal physician. So if you're listening to this live or recorded, please, I know I get so many questions every week by email and messages on social media. I am not your personal physician. I'm not. I'm sorry. This is for educational purposes. I want you to grow your knowledge base. I want to share information with you, but decisions about your personal medical care have to be done with your primary psychiatrist, primary care physician, nurse practitioner, etc. Because I don't know all the nuances about your case. I can't just haphazardly give you information. There are doctors out there on social media who'll do that. Well, be leery of them, okay? Because to just give out random advice when we don't know the full story, that's irresponsible, okay? All right, so number one, primarily, right, I always recommend folks to do some non-medicinal interventions as their primary intervention. We have so much evidence that counseling, therapy, support groups, combination of the above can be very effective for individuals, meaning many folks don't need to utilize the meds that we're about to review. And I don't want people to lose sight of that. And I really can't stand it too. I'm going to say a pet peeve real quick, because you know me, I complain a lot. I'm a cynic. I can't stand it when clinicians get very dogmatic. I also can't stand it when I see peers trying to assist someone going through addiction recovery also becoming very dogmatic. So both clinicians and peers who get very dogmatic that there's this one set path, right? Or the method they used, or the method that their loved one used is what's going to work for you. And I understand it's coming from a place with good intention, but sometimes the execution is poor, right? Because we have to understand that everyone is different. And I know that's a cliche phrase, but I mean it. Everyone is different. One person's drinking issues, one of the root causalities may be that, there's a long family history, right? And they were exposed to alcohol very early in their life. They've used it as a coping strategy. For another person, the root cause may be their depression, and the drinking is actually a manifestation of how they're coping with their depression. For the next person, it may be related to trauma. For the next person, they're struggling with 3 different other substance use disorders, and alcohol is another one of them, right? Everyone is different. One person may really resonate with them that AA works. Another person says, for AA, AA doesn't work for me. I don't like that higher power concept. I'm going to do something called smart recovery that focuses more on skills and strategies and cognitive behavioral therapy. Other folks say, I don't like small groups. I need a one-on-one counselor and a therapist. And when you're doing therapy, do you want to do motivational interviewing, which is a known, proven technique that is helpful? Do you want to do cognitive behavioral therapy, which is a known, proven technique that is helpful? Do you need an intensive outpatient program? Do you need a partial hospital program where you go 3 days a week, 5 days a week? Everyone is different. So it is important to explore the spectrum of non-medicinal interventions, partial hospital programs, intensive outpatient programs, one-on-one counseling. What type of counseling and therapy do you want to do? There's different modalities of therapy. There's free support groups and peer groups. Like I said, AA, Smart Recovery. Try different ones during one portion of your recovery, one chapter of your life. One methodology may resonate with you and be helpful. And then in another chapter, you may say, this is not for me anymore. And then my advice is move on and try something else. See what resonates with you next. The point is, both you going through this and those trying to help folks got to be flexible, got to be adaptable, got to be open-minded. And non-medicinal interventions are important. Healthy lifestyle changes, right? I want people to realize that, because when we jump into this now, into these pharmacological agents, I'm not obtuse to the fact that those are crucial, if not more vital, in my opinion. These are a tool to help all the things that I just said, and I mean it. And think about it, right? I would be obtuse to think that these pharmacological agents are the solution. If what I'm about to list for you is the solution, we would have stamped out alcoholism, right? We would have stamped out addictions related to alcohol use. Alcohol use disorder would be gone. I just prescribe this to everyone. We'd tell everyone, let's just put this in the drinking water. Instead of the fluoride, let's put in Naltrexone and Acamprosate in drinking water, in the tap water, and we just stamp out alcoholism, right? So think about what I'm saying, right? So let's not lose sight of that as we jump into it. But again, for those who like to vilify psychiatry and say psychiatry is a scam, that's being obtuse, and that's just having an agenda. Because there is evidence, what I'm about to review in just a second here, can be helpful to certain individuals. It's not for everybody, but to dog and dismiss and criticize medications that, yes, have plenty of side effects, but to dog them without understanding them, and to dog them if they could be a useful tool, a life-saving tool for someone, a life-changing tool for someone, then I'm sorry. You're a narcissist. It's more important that you're right and your agenda's right than allowing people to utilize a tool for a short-term, intermediate-term portion of their life to maybe change their life, right? So Co-Sun says, can healthy lifestyle choices are a better choice than pharmaceutical? I think they are. In the long run, healthy lifestyle choices are going to be sustainable. You're not putting chemicals in your body. You don't have to deal with side effects from meds. There's less cost because you're not spending money on medications, all those things. But what I just said here, Co-Sun, is that for certain chapters of someone's life and their recovery path, they might need the assistance of medications for the shorter intermediate term, right? So it's taking out the judgment and taking out that stigma when someone might need some of these things. And I think that we have to have a balanced perspective, right? Because if you or your loved one was in the valley of alcohol use, I mean, I'm drinking so much and the drinking has become so disruptive that I can't even function at work. I'm neglecting my kids. I'm not even taking care of myself. I'm not eating. I'm not showering. I want to die and end my life. Even if one thinks that meds are not for them, they're leery of medications, they're anti-pharma, anti-psychiatry, would you not want to help yourself or help the loved one by throwing the kitchen sink at this sucker, this evil called alcoholism and alcohol use disorder? Hell yeah, I would. My loved one is going through, I'll say, let's throw the kitchen sink at this and we'll clear out the mess later and we'll get you off these meds later. But your life is worth exhausting options. That's my attitude. Okay. So let's dive into it. So, to answer your question, yeah, I'm all about healthy lifestyle choices. I'm all about non medicinal interventions. I believe AA works. I believe smart recovery works. I believe motivational interviewing and CBT works. They work, but sometimes you need a little more temporarily. So let's talk about some of these options one by one so that we can get to our second topic today. So let's first go over a few options that are considered first line agents. Okay. And I want to make sure I give credit to uptodate.com. They didn't want to sit here creating a bunch of, novel graphics. So took these summary images from them. So I want to credit them. Please don't get me in trouble, Up to Date. So we pay exhaustive mafia fees to even access your resources. So, all right. So many of you are familiar with naltrexone, but naltrexone, it comes in two different forms that could be used for alcohol use disorder. It comes as an intramuscular injection, so a shot that you get, in a bulky muscle, whether it's in your shoulder area, your gluteal muscle, but it can comes as a shot that you can get conveniently once every month. That's not bad, once a month. It also comes as a oral tablet. Okay, so let's talk about that. So naltrexone intramuscular injections. You can get a 380 milligram intramuscular injection every 4 weeks. To be fair and balanced, right? There are side effects. Side effects include injection site issues, right? You can get infected, cellulitis, etc. You can get headaches. There could be some dizziness. I would say nausea is one of the most common. So nausea, unfortunately, happens. And that could be problematic, right? Especially if you're early in recovery or actively drinking, both. You kind of get screwed on both ends of the spectrum, right? Chronic drinking can cause tons of GI problems, right? Dyspepsia, stomach upset, you're more prone to acid reflux. You can be nauseous from chronic drinking itself. And even during the withdrawal phases, you can be nauseous and have diarrhea. So unfortunately, GI issues can be problematic at all different phases of alcohol use. And then now, what are we saying? We're adding something that's supposed to help your alcohol use, but yet in itself, it can then now compound nausea. And that really is. I do see that oftentimes as a very common rate limiting factor, whether you get this intramuscularly or orally. I would say probably more with the oral, in my opinion, but nausea can be a side effect. Okay. And yes, this is something that goes through the liver, just like alcohol goes through the liver. So there could be a chance that your liver enzymes could get further exacerbated. Something that needs to be monitored with blood work along the way. Okay. So, when the nice part, and I want to highlight this here, if you look at the far column where it says dosing and monitoring considerations, one of the reasons this is considered first line, right, is not only because, we do see that there is more robust evidence for this compared to some of the other options we're going to talk about today, but this could be utilized while drinking is still happening. So there's this misconception that one has to already be sober before using this. Okay, no, you can actually use this even while active drinking is happening. Obviously there are meds you don't want to mix with alcohol use while alcohol use is active, like benzodiazepines themselves, because benzodiazepines, which we'll talk about later, they're essentially almost like, and I'm not using this as a scare tactic, but they're almost like pill form, prescription grade alcohol. So like taking benzos and alcohol would be a bad mix, and that could just exacerbate, drowsiness, sedation. It could make you stop breathing, literally. But this is something that you can take even when drinking is happening. So it doesn't have to be this conditional if-then. If you stop drinking, then we can use this to help you. No, it's like we can use this to maybe already start attenuating or mitigating the amount you're drinking, the amount of heavy drinking days. Maybe this will even get you to start having some sober days. Okay, maybe this will blunt the reinforcement and pleasure one gets. So again, this is highly theoretical, but what we believe that to some degree, what naltrexone is doing, it is, essentially blocking certain opioid receptors to try to stop that reinforcing effect that alcohol gives you in that conditioned pattern behavior. Thus, kind of what I said, you can use this even when drinking is actively occurring, hoping we can gain these benefits and maybe get you on that path of sobriety, or at the very least, harm reduction, reducing heavy drinking days, binge drinking days, and number of days per week. Okay. So again, there is an oral version. I'm not going to review all the ins and outs because it's very similar. But what is the difference? Why have oral and the injectable? Because look, the oral version, let's just, right? I mean, non-compliance happens. So forget, take out the idea of like, oh, this idea of non-compliance is somehow unique to patients who are drinking alcohol or having problems with alcohol. Look at me. Like I had some kind of upper respiratory issue several weeks ago, bacterial issue. They gave me a 10-day course of antibiotics. I missed 3 days out of the 10. Good Lord. It's a once a day regimen. I couldn't even maintain compliance for a 10-day regimen. How many of you can relate to that? Right? How many of you have had non-compliance with your medications, right? And now we're talking about an infection or non-compliance for your vitamins or non-compliance for some workout supplement. But now we're talking about non-compliance with something that can affect your drinking behavior when you're in addiction recovery. But now we're talking about something that, if not taken appropriately, can increase the risk of your relapsing, having some regression in your recovery or setbacks, right? So stakes are higher. So if an individual is saying that, gosh, as much as I feel like maybe this is helping me, it's reducing cravings, it's reducing the heavy drinking days, remember that with naltrexone, there is a injectable version, and that will obviously, look, the catch is you still got to go to the clinic once every 4 weeks. So you still have to have motivation, right? You have to have motivation to show up for that appointment to get the injection. But if you could do that, and if you could be motivated to do that once a month, at the very least, you will have the naltrexone in you for the entire month. So that is the big advantage to having someone, maybe, especially the early phases, in my opinion, to just guarantee compliance while you're in that ambivalent stage, that healthy side of the ambivalence, the unhealthy side of the ambivalence. Maybe try to get on the injectable as soon as you can. Then consider the oral later if you want to stop getting poked and getting the injection. That's kind of how I view it. So I do think it is advantageous, in my opinion, to utilize the injection, right? And again, look, the other way to think about it is maybe you do some test doses of the oral first. Make sure that you're even tolerating this compound, this chemical, before you commit to having this in you for 4 weeks, right? And that's usually how most people will do it. But I would say test it out, keep that window, as tight as possible. And once you've established, I can tolerate this, switch to the injectable in the early phases. That's my opinion. Okay. So next, let's talk about another option. And I do think, and I feel bad for good old Acamprosate, or the back in the day, the brand name used to be called Camprol. I think Camprol kind of got a bad rap because actually, when you analyze the clinical research and the literature and the stats and the power, Acamprosate actually has decent evidence. It actually has decent evidence of being effective for outpatient-based treatment for alcohol use disorder and recovery. Now here's the catch. You see the catch. Look at the column right next to the name of Acamprosate. I'm laughing because you think it's mundane and it's rudimentary. I'm telling you, that is a huge problem. You have to take this TID, meaning 3 times a day. Okay? 3 times a day. Good Lord. How astronomically high do you think non-compliance will be when you need to take a med 3 times a day every day? I'm going to tell you right now, I know I'm kind of obscured by the image here. I would have a hell of a hard time staying compliant with that. Okay, so I'm not scaring people away from it. I'm just highlighting the reality. When people say Acamprosate sucks, Camprol sucks. Well, I said, well, have you been taking it compliantly 3 times a day? Inevitably, in the 14 years I've practiced, most people say, no, I'm taking it compliant, 2 days a week, 3 days a week. That's tough. That's tough. So I just want to highlight, as rudimentary as that sounds, that is a tough regimen to stay compliant with. Okay. Acamprosate is a different concept. Acamprosate is not an opioid blocking agent. This this is oversimplification, but basically it promotes GABA, GABA. It modulates GABA tone in your brain. Okay. And especially in recovery and early recovery, we do feel that GABA and glutamate, again, an oversimplification, but GABA and glutamate are kind of out of whack to some degree, and GABA receptors need to recalibrate. Okay. So there is some theory that, this is kind of a mild, low grade methodology of promoting GABA to some degree, especially when you're trying to cut back on alcohol in the early phases. Side effects include GI issues like diarrhea, dyspepsia, stomach being upset. The neurologic ones, I haven't seen, it's hard to say. I wouldn't necessarily say this induces anxiety. So I actually don't agree with some of that. Insomnia could be there. Dizziness. Yeah, dizziness for sure. So I'd say dizziness, insomnia. There could be some degree of sedation, but definitely GI issues with the diarrhea. And there are some renal considerations. If you have some renal impairment, you have to maybe adjust the dosing of it because this is heavily renally cleared. But again, this is another viable option. I would say this is lumped into first line treatment. In my opinion, I would tier naltrexone, whether intramuscular or oral, as the first option. To me, this would be the backup option. I do believe, in my opinion, that naltrexone has more robust data than Acamprosate, but I actually don't think Acamprosate has terrible data. I think people who say Acamprosate is useless don't really understand the literature. And also, I think there is a compliance concern when it's so hard to take a med 3 times a day. Okay. All right, let's see. So Kosan has a question before we move on. I'll read it here. It says, can naltrexone help bridge the gap between non-compliance, sobriety, and fear of health-related issues related to heavy, medium-term alcohol use? Well, yeah. I might be misunderstanding your question, but I do believe if you can even use naltrexone as a short-term intermediate catalyst, right? If that in itself, right? Let's say if you test out a few doses in the short term, maybe a week or two of the oral, and you say, hey, it's tolerable, I can handle the side effects. You switch the injection. Again, at least right? If you can be motivated to go to a clinic once a month, even if you could just go 2 times consecutively, 2 months of something that could genuinely help you reduce your alcohol use to sustain some sobriety. Imagine how much more capable and how much easier and motivating it would be to then try to then engage in counseling and therapy, to not jeopardize how you're functioning at the workplace, to maybe then focus on taking care of the other underlying causalities, your depression, your anxiety, right? The hope would be you could be that much more engaged in treatment. You can be that much more willing and motivated to do these healthy behaviors, that the totality of all those things, right? Non-medicinal interventions plus lowering your drinking, the actual health, the toll it's taking on your physical health by the alcohol itself in your body, like Dennis referred to earlier. That it almost like, can that just even be a catalyst? So I could even see that being a bridge, as you're saying, maybe not something you would need to use long term. So again, each person has a different pathway. Some people need naltrexone for an entire 6 months in a row so they can sustain those improvements that you're referring to. So again, every person will be different. There's not going to be some rote pathway, well-written map for everyone. I typically recommend, and professional societies typically recommend, trying to do the naltrexone for at least 6 months or so, and then reassessing if you want to keep using it or not. Again, predicated that you're not having liver enzyme issues, too many side effects, etc. So let's look at a few other options that, I would say are probably not first line, but like alternatives. Some you may have heard of. Some have mixed literature, so not as strong evidence as the first 2 options that I showed you, the naltrexone and Acamprosate. So we'll be briefer here so we can get onto our topic about protracted withdrawal syndrome from benzos. But very quickly, some of you have heard of this one. This is the old school med. I rarely ever see this used anymore. I think in the last decade, I've seen it used once. It wasn't prescribed by me, but I had a patient who I inherited that was on disulfram, or what used to be called antabuse. Now, how many of you here remember that word, antabuse? There's got to be someone in this chat. There's at least 20 of you watching right now. Someone here is at least in your 40s or above, like me, who knows the term antabuse. This generation, the young generation, probably don't know what that is. I shouldn't say that. Maybe some do. But disulfram or antabuse was that old school treatment. So I'm going to be brief because we barely use this anymore. But it's a medication you would take. And literally, if you were to drink, antabuse would prevent. Lisa remembers. So if antabuse is in your system and you drink while you are on antabuse or disulfram, it will allow the buildup of a toxic metabolite or byproduct of alcohol called acetaldehyde. That's the component of alcohol that makes you feel gross and nasty and flushed and nauseous. And it's not just going to make you feel a little ill, it makes you feel really nasty. I mean, it really builds up when you have disulfram or antabuse in your system. So really what it's doing is it's almost kind of like this aversive conditioning, right? Oh God, every time I drink, I'm puking my guts out and I'm flushed as heck and my blood pressure is going up and I'm having a throbbing, pulsating headache. I feel nasty. And the hope is that that has this kind of this negative effect, this negative conditioning that I now am going to associate this crappy, crazy feeling with drinking, and I don't want to pick up a drink anymore. It's conditioning, right? So that's essentially what it is, chemically induced conditioning. The problem is, right, I also know that if I don't take this, I'm not going to feel nasty, right? The other concern is people can push the limits and get into some hypertensive crises, feel really gross and nasty. In some cases, there have been reports of seizures occurring if you push the limits too far and you're just trying to override it. So it really just kind of, over the years just fell out of favor because we looked at other things that didn't rely on kind of just this behavioral conditioning model and really just trying to reduce cravings, trying to reduce the reinforcement of the pleasure, trying to balance and modulate GABA. So again, I'm not saying it can't be used or it isn't being used as we speak. I would just say it's definitely not popular anymore. But that's the history of disulfram or antabuse. Another one I do see used from time to time. I don't personally do a lot of it because I do think there's mixed evidence for this, even though it's listed a little bit higher than a few other options here. But Topiramate, or people know it as Topamax, or it's nicknamed Dopamax because it makes you feel dopey. Sedation is kind of a problem with Topiramate, but Topiramate, again, promotes GABA, G-A-B-A. Alcohol acts on GABA. Benzodiazepines act on GABA receptors. So Topiramate promotes GABA in a similar way. So I'm going to be very brief here. Topamax is used for migraine headaches. A lot of psychiatrists, even though I don't think it's great evidence for bipolar disorder, still to this day, many psychiatrists still try to use off-label Topiramate or Topamax for bipolar disorder. Those are its most common uses, but there are some specialists who will utilize Topiramate as part of an outpatient regimen for alcohol use disorder. And again, I understand the theory. It's kind of akin to, it's not the same thing, but kind of akin to what you're thinking about when you're using things like gabapentin or even to some degree Acamprosate. Is just a slightly different methodology of modulating GABA or GABA. So you can see the side effects here on the screen, so I'm not going to read them off. I'm going to be quick here, not because I don't believe it can help certain individuals. It's just not commonly used. So the most common ones are going to be the Naltrexone oral or intramuscular or Acamprosate, but this is out there, so I figured I'd highlight. It's very minimal use, kind of like the disulfram or antabuse is. Okay, so Let's move on. Last couple slides here, and then we will move on to our next topic very quickly. Mixed evidence, minimal evidence of being super helpful. Some people do use gabapentin. Gabapentin promotes GABA. And typically, gabapentin is used for neuropathic pain, so diabetic neuropathy, other nerve related pain disorders. It dampens pain signals for nerve pain. So that's what it's traditionally used for. And people have, take thousands of milligrams for those neuropathy situations. Now, look, this is not nowhere near. So let's be clear. This is nowhere near the potency of, let's say, Xanax or Valium or Klonopin. By no means, right? But interestingly, my state count might be a little wrong here, but the last I checked, in about 9 or 10 states in the United States, 9 or 10 states have now considered gabapentin a controlled substance, even though on a national level, the DEA does not regulate gabapentin as a controlled substance. So, meaning, I do believe there's truth here that some individuals, and that's why, again, I'm not going to be dogmatic, some people may benefit from gabapentin's GABA modulating properties to maybe ease some of the kind of withdrawal effects from alcohol use. But it is so less potent than benzodiazepine. So so D77 said, I've tried using GABA for opioid withdrawal and it didn't do to it. Yeah. And yeah, some people use an opioid, some people use an alcohol withdrawal. But again, in theory, I could see it. Because look, here's proof how I think both concepts are true. In theory, it could help some folks, but I also let you know about the concept of very low potency. Why do those 9 or 10 states regulate gabapentin as a controlled substance, even though on a national level it is not labeled as a controlled substance like Xanax or Valium, right? Because in some of those states, they have had some problems. People who are desperate and can't get their hands on other drugs, or let's say benzodiazepine prescription drugs, are resorting to just piling up bottles of these things. They're taking it from seniors. They're diverting these drugs. They're taking their relatives and they're taking bottles. I'm talking like a month's worth, 2 months worth at a time, consuming them all or boiling it down and then, taking it after they do that, like in a concentrated form, all of that effort to then, it will at some point when you take that much, I'm talking tons of it, then you can mimic getting high off of benzodiazepines. So again, two concepts. It does really act on GABA. The problem is potency, right? These folks are taking tons to try to induce a high, similar to the high of using benzodiazepine. But this is what's going on. People are doing this, and this is why now some states are regulating this as a precaution and regulating gabapentin as a controlled substance. So this is why I'm saying I do believe there are probably some people, maybe if you're sensitive enough, gabapentin can almost help you in a way as if you were taking an actual benzodiazepine. Okay, but for many people, and I've heard similar comments from my own patients, D77, a lot of people just kind of look at me and say, what was the point of me taking that, right? So it's mixed results. I would say, when I say mixed, I'd say probably more skewed towards most people don't find it too helpful, in my personal opinion. Okay. And then lastly, before we move on, some of you may have heard some of these things. Some of these are very out there. Some of these are old concepts. People have even tried applying things like Chantix, things that are used for smoking cessation, which is at the bottom there. Ketamine has gotten a lot of publicity about, being the next new thing to have people stop drinking. I would be a little leery. If you live in the Chicagoland area, you probably have heard these commercials on the radio. Come to the IV ketamine clinic, where ketamine is life-changing to cure your depression and PTSD and OCD and your addictions and your alcohol use disorder. I'm sorry, guys. As much as I have even talked about ketamine or esketamine on my YouTube channel here, and I do think it has its merits. Ketamine's not a wonder drug, right? And what do these places have in mind for you? Charging you anywhere from $500 to $1,000 a dose, right? So be leery. Okay, I'm not saying that ketamine can't be something that could be used as a catalyst to maybe snap you out of or kind of help, you know, you in the early phases of recovery. Because I do think it's a novel concept, and I do think that because it modulates glutamate and GABA indirectly, maybe there is truth to that, right? But until proven otherwise, let's be careful, and let's not get taken advantage of when people are trying to just use you to feed their cash cow practices, right? So, exactly, KG. I knew KG would come in with a comment. KG, I can always. KG, you know what, KG? I swear, you and I have to take your phrases, put them on mugs or t-shirts or something or stickers. And because you are the creative, KG says ketamine equals the best new thing since sliced cold bread, parentheses special K. So KG's full of these one-liners that we gotta start some kind of merchandise line, right? You know, and all these other mental health clinicians on social media, YouTube. I'm not, whatever. Good for them. I'm saying this partially out of jealousy, but also just kind of rolling my eyes. Inevitably they roll out their merch, right? And it's got like kindness for everyone, right? I'm so snarky and cynical. That's just not me. We would have to do something like this, KG. We need edgy one-liners on stickers and mugs, but you come up with them, we'll do some split, right? I mean, you're the one-liner king. So we're gonna, I don't know, we'll do like a 66-33 split. You getting the 66, and you just leveraging my platform and my reach, and we'll come up with something. We got to come up with some merch line later, but it's got to be this kind of snarky, edgy kind of theme like that, because that's more me than the corny stuff. Okay. But anyways, but here are a few things just for you guys to look at as I had it up here, okay? But bottom line, guys, okay, let's pause before we move on to what I know is probably an interesting topic, right? Protracted withdrawal. But what questions do you guys have? I'm going to pause just for a minute or two. So questions about those things: naltrexone, acamprosate, even the disulfram, topiramate, or just the concepts in general about recovery in alcohol use disorder. Whether it's, I know we were focused more on kind of this outpatient phase of treatment, because I know some of my viral vids have been more about just the acute alcohol withdrawal, what detox looks like, how to do detox. So we've talked about some of that in some of my evergreen videos, and that's how a lot of my subscribers have been here. So that's why I figured that part I'm not going to focus on today. But since we're at the Q&A part, any questions at all, I'm going to give it a minute, and then we're going to move on for the sake of time, since we started kind of late today because of my technical difficulties. But any other questions about those pharmacological options to leverage? So which are the best to be used before completely stopping drinking? I would say, KG, without hesitation, the naltrexone. I would say whether it's this right here, the oral version, which you could take as a tablet, or the intramuscular version. And the reason that I say that is the following. Because it is really more of kind of like a opioid blocking medication, right? We're not adding another source of like GABA, right? If you were to take, we use like Valium during detox, right? Which is essentially replacing alcohol. We use lorazepam during detox. But if I were to give you lorazepam and Valium during drinking, GABA, tons of GABA, right? Pill form alcohol, essentially, we're going to overdose you. You're going to be sedated. You're going to stop breathing potentially, right? Bad mix. If, even other like sedating GABA like things, sometimes you can have a synergistic effect and get a lot of sedation, dizziness, lethargy, etc. So different mechanism, right? The whole point, again, some of this is loose theory, so I'm not going to oversell it, but the whole point is we're hoping that because it's an opioid blocker, right? It's not about, like people get confused. They're like, well, I'm not using heroin or oxy. I'm drinking. Why am I getting an opioid blocker? It's because we're trying to block and blunt some of the pleasure derived the dopamine related reinforcing behavior in the nucleus accumbens, right? So the kind of the conditioned pattern that you get when you get that hit of pleasure, the reinforcing pleasure you get from drinking. So can we, even when you're drinking, like you said, when you're still drinking, will that binge of that 12 pack not feel as good, not feel as satisfying? And you say, this kind of sucks. And I've been meaning to, and I've been motivated to, but I'm still drinking, but maybe it just doesn't feel as good. That maybe it will help you be that, catalyst to cut back a little bit or take that final step to reduction to stopping, right? So that's the whole point. So the whole point is to utilize that even if drinking hasn't stopped. So I would say hands down, KG, in that scenario, probably the naltrexone combo. Now, again, the issue is that in itself can raise liver enzymes, and if you are drinking heavily enough, chronically enough, you may already have raised liver enzymes. So something that has to be taken into consideration. Might need to do some blood tests, get that checked, before starting. Okay, depending on your situation, it's not a hard and fast rule. You have to get liver enzymes checked, but to check. So. Last comment here, it's more of a comment than a question. Kosun says, when I stay with my girlfriend who doesn't drink, I stay sober but tend to have nightmares, and she tells me I shake and tense up a lot when I sleep. Yeah, no, yeah, it doesn't even have to be withdrawal per se, Kosun. So alcohol use, it really messes with your sleep cycle, right? And look, here's a comment, right? There's no argument. Drinking before bed probably reduces what's called latency to sleep onset. Fancy way to say time it takes to fall asleep. That's why people say, well, I have just a little sip, a little glass of wine, a little spirit before going to bed, and I knock out. Yeah, that's accurate. It probably does make you go to sleep faster. But what happens is it messes with, typically you go through multiple cycles of sleep per night, messes with the timing of the cycle, time spent in each portion of the cycle, more prone to waking up, becoming a lighter sleeper, having more awakening. So it's not even about withdrawal, but during active drinking, sleep cycles get effed up. Especially after the short term, there's like a honeymoon phase where the alcohol might help you get to sleep a little faster. It doesn't mess up too many things, but eventually starts getting all your sleep out of whack. And then disrupted sleep itself becomes a risk factor for perpetuating your drinking, preventing you from getting on that path of recovery. And even after recovery, let's say you're sober, there can be, this is not debate, it is a known fact that your circadian rhythm or your sleep cycles, even when in early recovery and sober, can be messed up for months. In some patients, even for up to half a year. And we know this because we have done sleep study research in patients in early recovery who are even sober. And man, it can take a while for your circadian rhythms to reset and get back to a healthy pattern. Okay, last one, and then we'll move on. So Kosun says, where is the line between withdrawal and delirium tremens? So to be clear, to be correct here, delirium tremens is a part of the spectrum of withdrawal. That means your withdrawal's gotten really bad. Okay. So delirium tremens is a part of the withdrawal symptoms syndrome. You just don't want your withdrawal to get to the point where delirium tremens starts. Okay. And maybe the way you're trying to ask the question is, where does delirium tremens start? Delirium tremens, the first word of that term, delirium, means if delirium tremens is there, you will not be with it. You will be out of it. You are disoriented. So delirium means you have the term is waxing and waning sensorium. For a few hours, you might be lucid. You know your name, your date of birth, year, month, date, where you're at, what you're doing. And then several hours later, where am I? You think you're at some other place. You don't know the circumstances. You're confused. You could be hallucinating, agitated. And part of delirium is not just the confusion, but your vital signs are really out of whack. Heart is beating out of control. Blood pressure is through the roof. Sweats, confusion, psychosis, and hallucinating is happening. So when you've crossed that line and that waxing and waning confusion and these vital sign changes have happened, that's called delirium tremens. And trust me, if you have delirium tremens, you wouldn't be sitting there saying, "Do I have delirium tremens?" No, you would have been hospitalized, or someone has called 911 in public for you, and you're going to be in the emergency room, and then you're going to be admitted to the intensive care unit. That is delirium tremens. It requires, you will be in the ICU because you could die from the DTs. Okay. So if you cross that line into DTs, there's really not like, oh, I just came back out of it. It's like you were committed, like you were having DTs now. And now it's a question of how long will you be in the DTs? Okay. So milder withdrawal is when you're having, and when I say mild, please don't take me wrong, guys. It's nasty. Okay. I'm just saying milder than DTs. Like when you're in kind of the portion of withdrawal prior to the DTs, it's, bad sweats, nauseous, you're puking your guts out, diarrhea, goosebumps, shakiness, heart is beating fast, blood pressure is up, agitated, anxious, insomnia. So it's all those things, but then confusion sets in, vital signs go totally out of whack, hallucinating, that's the DTs. And you need to be in the ICU. You need to be in the intensive care unit, or not saying everyone dies if they're not in a hospital. I'm just saying, man, it's really bad. It's really bad. And you're fortunate when you make it out the other side if you go through through the DTs without medical treatment. Okay. All right, let's talk next. So let's talk now. So part 2 of today. We got a lot of people today. It's been interactive, so we're going strong. I know it's already been a bit, so it's been about 45 minutes, but we're going to talk about protracted withdrawal syndrome, or PWS, from benzodiazepine. So a little bit of a shift, okay? So we're not talking about alcohol, but now we're talking about benzo and prolonged benzo withdrawal. So if you here are someone who feels that even after the first few weeks or the first few months after tapering off benzodiazepines, I'd love to hear your experience. That's what we're talking about right now. Because traditionally, when someone is doing it in a planned fashion, on an outpatient basis, or a planned fashion where you go into a detox facility or a medical unit, psych unit, to then taper off of benzos like your Xanax or your clonazepam or your lorazepam. Once you go through detox, we know for a fact, even after you're done tapering off, there could still be some residual withdrawal for weeks, maybe sometimes even a couple months. The worst of it, though, I mean, the dangerous part, right, where withdrawal seizures can occur and the worst of the physical symptoms can occur, typically is in the first week or two, first couple weeks. And again, please don't misunderstand. I know everyone, when I give these timelines, I get all these crazy comments. This doctor's an idiot. He doesn't know that people still suffer after. I said the part where you need to be medically supervised and the worst acute portion is a couple weeks, okay? Just to preemptively get ahead of those comments, because I get them all the time. But you can still have ongoing withdrawal symptoms for weeks, even months, okay? But the concept of prolonged withdrawal syndrome from benzos, PWS, means folks are indicating they're having residual effects. For them to reverse or taper off or subside may take, half a year, even up to a year. And then there are folks who are saying they're not reversible. I seem to have ongoing residual effects from coming off benzodiazepines that are now permanent. And now I have this permanent constellation of both physical and psychological symptoms that are just here to stay. And the belief is it stems from benzodiazepine use, or maybe even coming off benzodiazepines too abruptly. Either one, just from the chronic exposure itself, or maybe because of the lasting effects of stopping them cold turkey after having developed a dependence or tolerance, and from proposed theories and mechanisms of coming off them too quickly, having some kind of detrimental effect. Okay. And now it's to the point where there are several, societies, similar to like the PSSD network, right? Where more and more people are kind of congregating together, aggregating together, advocating as advocacy groups saying that there needs to be more awareness about PWS for benzodiazepines, right? And I believe one of the big networks, I could be wrong, I believe it might be based out of the UK. I think it's like the Benzodiazepine Information Coalition, I believe. Um, and there was a doctor, I believe Dr. Ashton, and who has the Ashton Manual, who published several studies about this concept of this proposed, PWS. Um, and more people are beginning to talk about this in a similar fashion to like PSSD at this point. So let's go through. Let me pull up one of these symptom charts. And again, this isn't mine. I'm not taking credit for this, but just to easily summarize this from you, right? See, I believe this is maybe from one of Dr. Ashton's publications and earlier works back in the 90s, I believe. Again, when you see these timelines, these are proposed timelines of these symptoms by Dr. Ashton and others who've also published similar things. I've found a couple other journal articles with similar time frames, but this is a good summary one. So they, on the left-hand column, they give you the symptoms. On the right-hand column, they give you kind of these proposed time frames that it may take for those with PWS to resolve, and even commentary about some that may be there indefinitely. So we'll just go down the list real quick. Anxiety. Again, and they're saying this isn't like some pre-existing anxiety per se that was there. I mean, they're saying this may be anxiety directly as a result of this kind of prolonged withdrawal syndrome, diminishing over the course of a year. Insomnia, look, that I believe. I wouldn't say the word theoretical. You heard my comment about alcohol use that when I was commenting to Kosun earlier. We know that insomnia and your quote unquote healthy sleep rhythm can be off for even up to half a year, like shown with sleep architecture literature, sleep study research. So that I believe. So I do believe, just like with alcohol, because benzos are essentially the prescription grade version of alcohol, that is something that could definitely be long lasting even after benzodiazepine cessation. Okay. Comments about depression, cognitive impairment, and that's one that's interesting. That's one they're saying that may last a year or more, and occasionally incomplete recovery is what they're saying. And that's an interesting one. And we'll go back to that one in particular because there has been controversial, conflicting research regarding benzodiazepine as a risk factor for dementia or Alzheimer's dementia and other cognitive impairments, right? So it's interesting, right? Because people independent of benzodiazepine use disorders or benzodiazepine withdrawal research are also concerned about potential long-lasting or harmful detrimental effects on cognition, or even being a risk factor for dementia with prolonged use of benzodiazepines. So that's interesting. Right now you have two separate fields. You have neurologists who are concerned about this, right, as well as psychiatrists and addiction specialists, right? So it's interesting. We'll come back to that in a little bit. Perceptual symptoms, so tinnitus, paresthesias, which is like a painful shock-like sensation or tingling, numbness, pain. So that's what I meant by physical, right? So not just these psychiatric kind of issues, but physical symptoms, motor symptoms as well, muscle pain, weakness, tension, tremors, shaking, muscular jerks, blepharospasms, gastrointestinal issues. So interesting, right? So that's kind of the constellation of various symptoms. Not everyone may have not the same experience, but this kind of encompasses what people feel could be part of a PWS or protracted withdrawal syndrome from benzodiazepines. Okay. Now, here's one thing, right? And some of these societies and these advocacy groups, and this is where we need to be balanced, right? And I know I I definitely got my fair share of criticism for my PSSD video, where I try to have a balanced point of view. You heard me loud and clear that I said I'm open to the idea that, look, I know SSRIs definitely. There's no doubt. I mean, they unfortunately, for a large percentage of patients, probably at least close to half or so, cause sexual side effects while you're on them, right? So to have this notion that there may be some people where there may be very prolonged or maybe an irreversible recovery, I could understand that. I could understand that. But I also said the literature that people keep quoting for PSSD is rather weak. And it's not robust evidence. And that part always pisses people off. But we don't have to be so binary, right? You can have both concepts. I could be open-minded and willing to understand that there could be such a conceptualization. Then there are people out there who probably have this, and we probably need more studying. But I can also say that the literature is actually pretty weak right now. And if anything, that means we need to study it more, right? So meaning that the literature is weak doesn't mean I'm closed-minded and it's impossible. I'm just saying the truth, that the literature is weak, right? Or else there would be far wider spread acceptance of this. Similar concept to this, okay? You already heard me. I can actually buy in. I think there's enough evidence to suggest some of these prolonged symptoms. So this one probably more than the PSSD, I would say, yeah, I think we already have evidence of prolonged recovery with sleep patterns and insomnia, prolonged recovery with rampant, anxiety issues, right? That could even be worse than maybe pre-existing anxiety prior to being on benzodiazepines, right? So I do think there's enough smattering of evidence for these individual symptoms themselves that could suggest maybe there is this syndrome that could be prolonged for a cohort of people. Not everyone, but a cohort of people, right? But current existing evidence, robust evidence, is rather sparse and limited. Same concept. You can say both things, that I could believe that this concept exists, that I can believe that some patients go through this, but the foundation of literature for this is rather weak, meaning I'm not saying weak so it doesn't exist. I'm saying weak, we need to study it more, and we should study it more. Okay? And here's an example of what I mean. I was going to show you this right away, but I wanted to give you that context because I don't want my next comment to come across as snarky or dismissive, but it's just a fact. A lot of these advocacy groups who are saying, like, this is rampant, this is all over, this needs more recognition, look, they always quote this. Even the FDA acknowledges this concept, they say, right? And if you look here at the bottom of this top page that's kind of cut off, it says, similarly, there were variations in the duration of the withdrawal symptoms that lasted from weeks to years, period, right? And they're quoting this from the FAERS, the FDA Adverse Event Reporting System. And most of these advocacy groups put this in huge quotes, kind of intonating, saying that the FDA is acknowledging that this protracted withdrawal syndrome is this specific syndrome, this entity that's out there. But that's the only thing they put on their website, that quote, right? And like almost in this bold one-liner, kind of like newspapers do, right? But look, this is the actual letter. And if you read this, it says, we evaluated 104 cases from the FDA Adverse Event Reporting Systems database of abuse, dependence, or withdrawal involving a benzodiazepine as a single drug substance. Here's the key phrase: reported by patients or healthcare professionals directly to the FDA from 1968 through 2019. So 104 cases spanning 51 years And some of these are self-report. And I'm not diminishing people's experiences, but I'm just saying is self-report, and we don't even know what the ratio is of reported by clinicians or hospital systems or clinics versus reports into the database direct from the patient or consumer, right? And if this is the thing that you're quoting as your big see, told you so, you need more than that. That's what I'm saying. Okay, guys? So when you're reading these on these, this is what they're referring to. So I'm just saying we need to do better. So if we want to better understand this, then we need to study this. And I'm open for us studying this, right? And the problem is, right, a lot of these advocacy groups, rather than having, like, I really wish there was more of a collaborative spirit. They almost don't help their own cause. I'm not being like hypercritical of this particular coalition or group. I'm just saying I read their website, and one of the commentaries is like, then even if you were to print this up and print up publications and you bring it to a doctor, the doctor doesn't even have time, and they're going to pull out their prescription pad and just prescribe you the next med. And yeah, is that false? No, it's probably true. It's probably the experience with most psychiatrists. I don't think they got that part wrong. But it's just kind of this attitude of just like, I don't know, that every psychiatrist is just evil and, they don't have a rapport with you. They don't care about you. They could care less about you. They're just ignoring you. They're treated. No, it's just like, why don't we study this damn thing, right? So why doesn't everyone band together rather than antagonizing and polarizing different groups or cohorts? The psychiatrists are bad and they don't know, they're in the dark, they're part of evil empire pharma. Well, then let's figure out, like, how do we vocalize to the NIH or whoever, some independent, like, the NIH throws around money like crazy. Look, if there's one thing that's coming out of this, whether you agree with it or not, and I don't care, whatever, if you're right, left, conservative, liberal, blah, 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 whether you like Elon Musk or not, at the very least, what I could say is spending is coming to the light of day, and people are now at least scrutinizing with a little bit more, transparency. Where the hell is all our tax money going to? And look, I can tell you right now, I didn't need Elon Musk to highlight this. I know that the NIH wastes tons of money on what I believe certain projects are rather frivolous. Okay. Frivolous things that have no shot in hell of ever translating into KG's funny. I've never met a psychiatrist I didn't like. Will Raj. Okay. There are some things they just spend money on that have no chance in hell at ever translating into some kind of discovery or a treatment intervention at all. Like, some of these things are just pet projects. There is rampant waste, okay? And that's not a unique statement. There's rampant waste in all branches of government. I mean, but even within the NIH funding and what the FDA does, oh my God, there's so much waste. There is so much waste, okay? So why can't we figure out how the hell, with something that is as widely prescribed and ubiquitously prescribed as benzos, right? Certain doctors prescribe benzos like candy. Valium for you, Xanax for you, clonazepam for you. Well, it's not like we're studying some rare medicine that only a couple of people are on for a rare disease, a genetic disorder that one out of like 800,000 people have. Everyone's on benzos. There's so many people on benzos. So why can't we get the NIH to do some relatively, there's always bias, but relatively unbiased study without pharma influence to see is there, something to this protracted withdrawal syndrome? And let's study it a little bit, right? I mean, I know that's hard because there's a lot of confounders and a lot of, I'm not obtuse to that, but we have to do better than, small case series, one person publishing something at an academic institution with 20 something people from their clinic. I mean, we got to have larger studies. So I don't know. I'm just saying we need to study this better. But let's go back now to the PWS concept, right? So we looked at proposed symptoms of protracted withdrawal syndrome. Now let's look at proposed mechanisms, right? Like, how do we explain some of the things, right? The physical issues, the cognitive impairment, the gastrointestinal issues, the anxiety, all the things we showed on the other chart. Maybe I should put them side by side. Let me see if I can do that. I don't know if I can shrink this one down since we already looked at that. This one over. Oops. Okay, so those symptoms we talked about earlier, and then these are the possible mechanisms, because I think it's important. Let's at least look at the theories, right? So they believe that, and again, so this one's a little loose. That first row, the anxiety, vulnerability to stress, in kind of a post-withdrawal period. But loose but correct. Learning of stress coping strategies are blocked by benzodiazepine use that are now exposed during the withdrawal period. Well, correct. That's not a technically incorrect statement, but a rather loose kind of correlation. Because look, if you talk to a cognitive behavioral therapist or ERP, exposure response prevention therapist, they don't recommend that you take benzodiazepines during exposure response prevention therapy, right? Because you can blunt the anxiety and tension that's supposed to be evoked for you to process and work on together with the therapist during that exposure technique or exposure exercise, whether you're doing that exposure exercise out on your own in between sessions, or maybe you're doing an exposure exercise during the session itself in a safe environment, with the therapist right there in real time. And if you're blunting the anxiety and the panic and the emotional response you're going to induce, then how do you work on it? And how do you then decouple your reaction? How do you then decondition the panic response and then condition healthier patterns? So there is evidence that benzodiazepine use, while doing these exposure cognitive behavioral therapy techniques, can actually blunt and even slow down the progress of and reduce the effectiveness of these exposure techniques and CBT interventions. So that statement's not false. So there could be a component of that, right? Like, again, we're not talking about so that line, when I said loose, it's like they're not indicating like, oh, this is like some chemical reaction inducing anxiety. They're saying now this is you without the benzo now almost kind of being exposed to the fact that you have not ideally optimally learned how to cope and deal and strategize with the anxiety, right? Now just kind of adding gasoline to the fire, right? Similar concept for anxiety and depression, so I'm not going to belabor that. Similar concept to the traumatic experience or PTSD-like phenomenon. So if we skip down to number 5, that's an interesting one. That's the concept I want to really spend a little bit more time. We'll spend a little bit more time on number 5 and number 6. So number 5, nervous system hyperexcitability due to persisting changes in GABA and benzodiazepine receptors. Okay. So that's what they're referring to is it's like because you have chronically been taking benzodiazepines, right? Just like what happens when you go through alcohol withdrawal, benzodiazepine withdrawal. Are you now kind of in this hyper excitability state? And again, this is going to be an oversimplification, but for the sake of time, if I'm chronically consuming this external source of a GABA promoting agent, right? And again, an oversimplification, but GABA is kind of that slow down signal, calm down signal, and glutamate is that like excitatory rev you up signal. That's an oversimplification, but let's just use that ratio, right? GABA slow down, glutamate excite, right? every day we kind of have like this like homeostasis where those two fluctuate throughout the day depending on the day time of the day, right? I mean, when I'm active and waking up, like I want a little bit more of that excitatory signal, right? The ratio skewed that way. And when I'm calming down to wind down, relax, go to bed, I probably want the ratio to be inverse, right? And want to have more of that GABA signaling going on at bedtime, right? So, um, but now let's say I'm taking benzodiazepines chronically, this external source. My body says, well, I can kind of lower my naturally occurring or endogenous GABA signal, because why should I keep pumping out so much when I have this external source of it, right? So you're getting external source GABA from benzodiazepines. Your natural endogenous GABA goes down, right? But then you stop. You stop drinking alcohol. You stop taking benzos. And now you got this low endogenous GABA, right? Because your body was trying to balance things out. And now your glutamate's too high relative to that GABA. The ratio is off because your body has not had chance to recalibrate it, right? So that's some of the theory about why there's this like excitability that happens during alcohol and benzo withdrawal. Why am I so revved up and anxious and shaky and my heart is racing, my blood pressure is going up to the point where my glutamate is in excess, which triggers seizures like alcohol withdrawal seizures, benzo withdrawal seizures. So again, that was an oversimplification, but there is some truth to that primitive notion or rudimentary notion of how I described it, right? A kind of excess excitatory signal. Now, the whole concept is where our bodies recalibrate, right? And eventually that levels out and then that withdrawal goes away, whether you got detoxed with benzos or, naturally it kind of recalibrates over time gradually, right? So the concept then is, well, what about if one has a really prolonged recovery from that? And that recalibration takes a long time, really long time, meaning months, a year, longer than a year. Yeah, I mean, I think it's feasible. Like why should every person have the same time course? So feasible. So back to my concept of there is evidence that people have different time courses, right? So I do think that there are going to be some folks who probably do have much more of a prolonged recovery, right? This nervous system hyperexcitability may last for months, maybe even longer, right? So what I'm saying is I'm not saying that this concept of prolonged recalibration doesn't exist. I'm just saying I don't know that we fully understand it for those who might genuinely have, right, this hyperexcitability for not just months, but like a year and a half, 2 years, or people who say they just never recover. That's where there is a gap in knowledge. That's what needs to be studied a hell of a lot more. And what also needs to be studied is not just that cohort of people, is just this concept in general. Is that even the reason why people who, even when sober and off of benzos for months, will say, my insomnia is rampant. I'm just on pins and needles. I'm physically and psychologically on edge, anxious, irritable, agitated. What is the reason, right? Can we just figure out with better imaging or fMRI or some other marker, right? I mean, I know that's a little bit of a fallacy trying to find all these holy grail biomarkers, but can we do a better job in trying to identify some kind of marker to tell us who are those individuals who may have this super prolonged course or maybe an irreversible course, right? And look, I'll put the chart back up in a second, but this is almost akin to, right, that theory or the notion of people who have kind of this hyper sensitive pain syndrome, right? People who have been exposed to so much chronic opioid use that you have now, right, almost as a survival mechanism, had an upregulation of pain receptors. Now you're almost in this like horrible cyclical cycle, right? You almost have a hypersensitivity pain syndrome now, right? You've blocked your opioid receptor. So, I mean, you've been, blunting pain so much with chronic opioid use, right? We have to remind ourselves, right, that pain is a survival mechanism, right? Even an infant who hasn't been verbally taught, like, don't touch hot things, you touch a hot thing, you pull back because it hurts. I mean, it is instinctual, it is primal, it is to preserve yourself, protect yourself. Pain in itself is not some vile, villainous thing, right? I mean, it's meant to protect you. If I'm getting punched and hit, I should move away or shield myself. If I'm touching a burning hot object, I should stop touching it. Move. So you can live, so you cannot be hurt, so you cannot be maimed, right? So your body, right? I mean, again, I know this is a rudimentary way to describe it, but it's like your body's like, hey, you're blocking and pain so much with all these opioids and opiates that it doesn't surprise me. There's been evidence, right, of upregulation of pain receptors to say, I got to be able to detect pain to preserve myself. But then what does that do, right? This chronic cycle. Now I'm in pain. I need more opioids, and et cetera, et cetera. So we've even seen it in the opioid realm, right? This notion of like upregulation of receptors, hypersensitivity, right? So why couldn't there be this hyperexcitability syndrome, this state, hyperexcitability state with the neurons that occur? We see it. We do see it happen. That part is not theoretical. We see it happen for acute withdrawal. I already said it. We know that's a part of why we see the vital sign changes, the withdrawal seizures. But I'm saying, is it far-fetched to say that some people that might not reverse as quickly and recalibrate as quickly? Happen for half a year, happen for a year, possible, right? Maybe not to the degree it's at during acute withdrawal, but maybe to a moderate or modest degree on a chronic basis. And I think, again, the big question mark for me, and what I need to see more literature, robust literature, would be, is that happening permanently or irreversibly for people? That's where I have some questions. I don't know. Prolonged, I believe. Permanent, I'm not sure. But is it out of the realm of possibility? No, I actually don't think it's out of the realm of possibility. I'd like to see more, though, right? And I'll talk to you in a second about why I don't think it's out of the realm of possibility. Now, I could buy into this theory, okay? Okay, so we also talked about, row 6 is another interesting one, structural or functional damage to brain tissue. So that's an interesting one because I will say, in the realm of neurology, there has been a fair amount of studies looking at long-term benzodiazepine use, benzodiazepine exposure in a more elderly population, senior population, and looking at risks for cognitive impairment, mild cognitive impairment, Alzheimer's dementia, dementia in general. And there's been mixed evidence. Early on, it really made a lot of sexy headlines, and of course, mainstream media latched onto it. Benzo use causes Alzheimer's. Of course, that's what the mainstream media is, right? Of course, that's an oversell and an overstretch, right? More, updated studies, even retrospective meta-analyses on even those early studies that made those mainstream headlines will say evidence is rather weak. We've even had studies that have showed opposite results, showing there is no risk. So right now, most of the recent meta-analyses indicate a very weak correlation or correlation, but needs more studying. So it's kind of in that gray domain. So to say it's an actual established cause or fact regarding being a major risk factor for Alzheimer's, correlation needs to be studied. That's probably in that domain. And interestingly, they've even looked at literally just brain volume, like in the frontal cortexes, gray matter, white matter. And they've had mixed results. They've shown some studies with volume loss. They've showed studies with no significant volume loss. A lot of them still say there's so many confounders. How does one control for the other variables? whether it be ongoing benzo use, whether it be alcohol use, etc. So, I mean, hard to say, but at the very least, there is some, I'm not going to say, again, rock solid, or we know for a fact it's a cause and effect. But again, even the meta-analyses acquiesce that, look, there's some evidence that there can be ongoing impairment long after stopping benzodiazepine use. And mixed evidence, whether it does or does not, in fact, lead to brain volume loss in certain areas of the brain, but just the cognitive impairment itself. So forget the structural change comment, but cognitive impairment itself, there does seem to be some, keyword some, evidence that in some individuals, I know that's vague, may have some ongoing cognitive impairment even after stopping, right? I mean, again, abstracts are abstracts, but you could read this abstract here. Like, here's an example. This is just one of many, though. So I'm not saying this is the one. There's many of these, right? And if you look kind of in the middle here, that long-term benzodiazepine use may lead to impairments in the areas of verbal memory, motor control and performance, and non-verbal memory, but not visuospatial skills and attention trust. The length of abstinence greater than 6 months indicates that these impairments persist well beyond cessation of benzodiazepine use. And this is not just this one study or abstract, right? I mean, this has been replicated several times, that when given cognitive batteries of tests in these research studies, that even half a year later, even sometimes a year later, there are differences, or impairments that persist, where we would have expected some bounce back because people have gotten past the acute or intermediate stages of getting off of their benzodiazepines. So, and this kind of ties into a lot of those, are you at higher risk for cognitive impairment or Alzheimer's studies that I was referring to earlier. So again, you've heard me say now, I believe that there probably is some evidence of prolonged cognitive impact, prolonged sleep impact on one's sleep patterns and insomnia, probably on anxiety because of that hyperexcitability, right? Why do I see so many patients have keyed up, on edge, anxious, and sometimes SSRIs and other non-controlled substances don't seem to touch it when people are in that intermediate recovery phase of trying to get sober from alcohol or benzo use, right? There is something to kind of a hyper excitability neuronal state. There is something to prolong. We know that insomnia itself is a risk factor for relapse within the first year of recovery from benzos and alcohol, because we know that that's how rampant insomnia is. So why is there such a hard time even with something as mundane as sleeping? If I know that people's cognition is not as good when they're taking benzos, just like I know people's sexual functioning is not as good when they're on SSRIs, why would it be impossible to have the notion that some people are going to have a very prolonged recovery with their cognition, to be as lucid and as sharp as they once were? I could understand it. Do we understand how and why? That's the problem. We don't, right? We don't know the exact how and why, right? And the underpinnings and the who is at risk for that, right? Some of the literature from, those advocacy groups will say, those who are at risk are going to be those who had higher doses, prolonged use, or those who had very, very abrupt cessation from decent amounts of that. Yeah, I mean, I don't disagree. Those are probably going to be anecdotal correlates, but that doesn't say much, though. I mean, I could have said that without even looking at some research or stats. I mean, that's anecdotal. I can say that anecdotally as well. So it's just, there's still unfortunately a big knowledge gap, right? Are there folks who have irreversible change? How would we measure it? How would we detect it? Who are those folks? Who is at higher risk? Is there anything that could be done to accelerate reversal? Can reversal occur? A lot of question marks, but But at the very least, if we scale it down, so if we take out the concept of irreversible, I would say prolonged. Yeah, I can definitely buy prolonged. I've witnessed people having prolonged struggles during, especially in year one. So not just a few weeks after stopping their benzos or a month or two. I'm saying, yeah, year one can be very rough. Not for all, but for, I would say, for many people, year one could be very rough coming off benzodiazepine. So I don't, that to me is not a stretch. I think when you say, hey, it's 10 years down the road, and I still feel like I'm attributing this all to coming off of benzodiazepines 10 years ago, that's where I don't know what to do with that. I'm just being honest. It's hard to say because that becomes into a very theoretical realm, right? Because again, one can say, well, is that attributable to X, Y, and Z and all these other factors? Or is that truly coming from a direct insult or injury or pathology from coming off of benzodiazepines, right? That's a different, I'm not sure. I don't know. But I would need to see more evidence to be more confident to say, yes, that's from your benzodiazepine use. Because look, if you ask me that now and someone, I know that's an extreme example saying 10 years down the road, but if someone said to me, 10 years post benzo cessation, I feel like that is the cause. That is the main attribution to why I have X, Y, and Z symptoms. I'll be blunt and honest, I'd be exploring probably 9 other reasons first, right? And that's where, let's say this syndrome, that irreversible kind of spectrum of the syndrome exists, where I would get it why a patient would be pissed at me, right? And say I was being misdiagnosed and treated with the wrong things for X amount of months, X amount of years, because Dr. Kim just didn't buy into this notion that I had this irreversible, really, really prolonged, not just prolonged, but prolonged to the point of irreversible, benzo withdrawal syndrome. And I'd say, yeah, because I don't know, because it's not really defined. We don't really have this well thought out right now as a field. So it's just question marks, right? So, but again, prolonged, yes. Irreversible, I'm not sure. Open-minded, but not sure, would like to see more evidence. Okay. And it's hard. I know that's a high bar, right? Because look, you've heard me before, even the notion of major depressive disorder. How does one know it's there? There's no blood test for it. As much as we'd like to believe we have biomarkers, and we're trying so hard to find the holy grail, right? Cortisol levels, this or that, genetic blah, blah, blah. We don't, right? So we do have a faith-based system. We have a faith-based system to say we're going to believe the patient is the measuring stick, the barometer, the reporter of these symptoms. And if we try our best with our eyeballs to see some observations that are consistent with depression, then we're going to call it depression. Right? I mean, at least I'm being honest, right? So then to say we're not going to apply that, let's just trust it and go on faith mechanism or system to irreversible, protracted benzo withdrawal, is that being unfair and biased? Yeah, probably. So I'm saying you're right. Right. So I think I have to sit here and try to figure out how to reconcile that. Because I'm not obtuse to the fact that a lot of this is kind of, we're working in the realms of man-made paradigms and trust me, bro, and anecdotes and pattern recognition, right? So it's a tough pickle, right? Especially if you are the patient who's saying, like, I am that person who has this irreversible form of PWS, right? Anyways, now I'm rambling. Oh my God, it's past midnight here in Chicagoland. But let's open it up. I'm still, I always want to have a little bit of Q&A. So there's a lot of people still here. So this is an interesting topic, I guess. We've had not just a handful of people spike over the course of the episode. We've had about, anywhere close to up to 20 people the whole time. So that's impressive. So it must be resonating with people to want to learn more about benzo withdrawal, prolonged withdrawal, alcohol use. So what questions you got? I'm gonna give 5 minutes, guys. So you got 5 minutes because my eyes are, I don't even know what I just dropped, but I dropped something. But sorry for the sound on the mic, but 5 minutes before my eyes are gonna close and I'm gonna probably go hit the sack. So open-ended Q&A. If we get some takers in the next few minutes, we'll talk and chat. If we don't get some in the next couple minutes, we'll shut it down and then resume the live series on Tuesday at 10:30 p.m. Central, 11:30 p.m. Eastern. So any last call for questions, any Q&A about the topics we talked about today, or just, I guess, any questions. It's free for all time. But so Eduardo says, last Sunday was my last drink in my life. I've only had hangovers, but I'm pretty sure this time I got DT. It was bad. I hallucinated and heard demons. It was scary. Yeah. Well, Eduardo, number one, good for you. Number two, if you haven't, you probably should consult with your doctor, whether it's your primary care doctor, nurse practitioner, even if it's primary care family medicine or a psychiatrist, just to be safe. Eduardo, I'd recommend that. Okay, so let's get that out of the way. Yeah, hallucinating, it's hard to say. I mean, there's two forms of hallucinating when you're coming off of alcohol. You could have something called alcoholic hallucinosis. I know it's a weird concept, but it does happen, and I've witnessed it before. It does happen. You can hallucinate without being delirious, meaning you are not confused. Like, you know where you are, what the year is, what day it is, what's going on, the circumstances. You're not confused, and you're not having this, I'm clear-headed, confused. That's delirium. So if you are not delirious, yet you're hallucinating, but you're lucid otherwise, that's called alcoholic hallucinosis. But if you're hallucinating while you're having this confusion and all these physical problems, like your heart's racing, your blood pressure's high, you're confused as can be, then that's called DTs or delirium tremens. If you're having that, you should get checked out either way. Okay, whether it's alcoholic hallucinosis or the DTs, but both are very concerning. But DTs is really like, basically it's an emergency. So I hope you're doing okay, Eduardo. But like I said, if you haven't, I would recommend getting some help. And look, if you're motivated, I'm glad you're motivated, right? Like, if you're saying that last Sunday was your last drink, that means you're motivated, man. And I applaud you. People here applaud you. And we're rooting for you. But you should strike while the iron's hot and take care of everything, meaning like holistically. So take care of your physical health, take care of your mental health, take care of your heart and your soul and your spirit. You gotta approach this as holistically as possible. But good for you. I'm glad that you're finding motivation, whatever your motivating factor is, whether it's your health, whether you're tired of spending money on alcohol, whether it's for your loved ones, whether it's for being able to work, whatever it is. Keep focusing on your motivation. Take care of yourself, Eduardo. But I'm glad you're motivated. Glad you're motivated, man. So, let's see. So KG asks, here's a question. So we got a question coming in. So, do you think that prazosin would be helpful for hallucinations, or maybe low dose Abilify or Zyprexa? Well, I would say, when people have alcoholic hallucinosis, right? Obviously, the root cause is alcohol itself, right? So the root cause is to figure out how to either, again, harm reduction, sobriety, etc., as a starting point. But yes, temporarily, we do typically recommend low dose antipsychotics, right? And again, key is it's not saying that you're going to need them permanently, right? I mean, we're talking maybe like a month just to be on the safe side, right? Weeks, a month, and then tapering off, right? And of course, the sooner you can get sober, the sooner you can cut back with some harm reduction, the sooner you probably don't need to be on those. But I would say more than the prazosin, probably low dose antipsychotics would be sufficient. And it does seem to help some folks. So prazosin, Yeah, I'd have to check. I mean, I would say off the top of my head, I would probably say I wouldn't really roll with that because prazosin, right? I mean, essentially, you're trying to, dampen, how do I put it? Like noradrenergic output, right? Like for layman's terms, like adrenaline output. You're trying to dampen fight or flight reflex. So it might help with nightmares because that's what we use it for off label. We use it, in complex trauma and PTSD to reduce frequency and vividness of nightmares and vivid dreams. Doesn't always work, but sometimes it does. And sometimes it can dampen some of the like physical aspects of fight or flight. But I would say, yeah, it'd be probably a tough sell to say that that's going to be as robust, keywords, as robust as using low dose antipsychotics for hallucinosis. So, D77 says, I've always wondered why alcohol and benzos together make you black out. Really good, informative live. Oh, thanks. I'm glad you found the live informative. Yeah, look, I would say this, D77, it's alcohol and benzos, they can definitely have combined, like you're saying, a synergistic effect. And what I mean by that is like it's almost like the sum is more than the each individual component that combined that you would expect to get as the sum, basically. So like 1+1=3, right? You're almost getting a higher net effect than each individual part combined together, theoretically speaking, right? So, and this is why we even see kind of a warning, right? When you drink and use benzos, it can basically dampen the signaling to your medulla and have you stop breathing. So literally you just stop breathing, and you never wake up again, right? That's one of the concerns, right? Whether it's with, opioids and alcohol, benzos and alcohol. But unfortunately, we do know that, benzos can cause memory impairment, recall impairment. But they can make you black out when they're used together. So basically they could just compound on each other. And if you think about it, it's like, again, benzos are essentially like alcohol. So it's almost like you're just adding more drinks. Just like take benzos out of the picture, right? D77. You drink enough, you black out. You drink enough, you might black out, not remembering anything that happened. So if I had, you know, if I had a 24 pack of beer and then I took, 4 milligrams of Xanax on top of it, essentially that's like me having 30 something beers, right? So you have to almost think of like these benzos as like drink equivalents themselves. There's no such perfect conversion chart, but I mean, I would say like essentially like a milligram of Xanax is like having a couple beers basically. So but yeah, it does happen because you have to almost think they're just going to compound on each other, almost have a synergistic effect to some degree potentially. So, unsafe thing to do. You really don't want to be taking them together, just like you don't want to be taking opioids and benzos together or opioids and alcohol together. Don't want to be taking those two. So, okay, last call. I'm surprised we still got a lot of people here, but last call, maybe one or two more. I'm going to give it a minute. If we don't get a question in a minute, I'm going to call it a night because even this insomniac is tired. Got a city day tomorrow. My kids got off for Monday, so I'm taking the day off Monday. So gonna spend a day in the city in Chicago. Picked a great day. It's supposed to snow 6 inches, but we'll see. Hopefully, we can still make the most of it. Just having a 1 day staycation to try to rejuvenate with a 3 day weekend before I go back to the grind with work on Tuesday. But all right, any other last minute question? But I'm glad for KG. D77, other people who've been asking for this topic for a while. I appreciate you guys giving me suggestions, so followed through on this one. So, okay, last call. Going once, going twice. If not, you guys all have a good night. I hope you guys get to sleep soon too. I'm tired, but I hope you guys have a good night. Please like and heart this episode. Give it a thumbs up. Please retweet it on your social medias. Help me get some more viewership on these live streams so I stay motivated to keep the live stream component of my YouTube channel going. And for you, I really appreciate you guys. So KG, D77, Lisa, the regulars, Dennis, You guys are great for always sticking with me, so I appreciate it. I don't know how you guys have the energy to watch these things, but I appreciate you guys. So, you guys keep me going, man. So, you guys have a good weekend. Please be safe. Hope you guys are healthy. There's so much flu and COVID and all this stuff going around right now. So, be healthy, be safe, guys. And yeah, I appreciate you guys. Have a good night. Take it easy, everyone. See you guys Tuesday night, 10:30 Central.